back after a short break. Welcome back to the last part, last two sessions. Last but not least, Dr. Khin is again with us here, and she will provide you two talks, two lectures, one related to small round cell tumors, and the last one will be about epithelioid soft tissue tumors. Dr. Khin, please.
Thanks, everyone. So the next talk is on small round cell sarcomas. And of course, this current WHO classification has come 8 years after the previous 4th edition. And as we all know, since then, there has been a wealth of new molecular data. And that's led to the reorganization of several categories. And one of the entities that has benefited the most from this has been the category of undifferentiated small round cell sarcomas of bone and soft tissue. So if we compare small round cell sarcomas as they were classified in 2013 compared to how they are now, and we can see that in 2013, small round cell sarcomas were simply under the heading of Ewing sarcoma, under the section of bone. In contrast to currently, where there is a separate section altogether on undifferentiated small round cell sarcomas of bone and soft tissue, and there are 4 segments to this section. So the first is Ewing sarcoma. The next is round cell sarcoma with EWSR1 non-ETS fusions. Prof has talked about those already. And then the next 2 are the CHIC or CIC rearranged sarcomas and sarcomas with B-core genetic alterations. And we'll talk about these and other round cell sarcomas in this talk. So small round cell tumors represent a collection of typically aggressive tumors characterized by uniform, monotonous proliferations of rounded cells with high NC ratio. And there is, of course, significant overlap between them, not just morphologically, but immunophenotypically and molecular genetically. So Cyril has already described what a promiscuous gene EWSR1 is. And there is overlap morphologically and immunophenotypically between individual sarcoma subtypes, and also between sarcomas and non-mesenchymal neoplasms. For example, a quarter of Ewing sarcomas can show prominent keratin expression and resemble small cell carcinoma. Ewing sarcomas can show variable strong neural or neuroectodermal differentiation and resemble neuroblastoma. So when we're looking at these, when we're trying to diagnose them, it should always be in the clinical context, in the whole clinical context. And one of the most important factors, as we know, is patient age. In this talk, hopefully, because most of us, of course, are diagnostic pathologists, and the majority of us do not have access to easy molecular genetics laboratories, or particularly have any of the sort of high-tech antibodies. So the aim here is for us as diagnostic pathologists to be able to as accurately classify these as well as possible on morphology and on the standard immunopanel. So we need to appreciate the subtle morphologic differences between different small round cell tumors, appreciate the morphologic spectrum of each, and also be familiar with the ancillary diagnostic techniques. So for us to know the immunophenotypic spectrum of each tumor, because as we might have guessed, there is no specific immunoprofile for any of these tumors. So we need to be aware of the whole immunophenotypic panel. And also we need to at least understand and know how to manage the molecular data. So as Cyril has already described, different small round cell tumors occur at different ages. So in very young children, we have these, neuroblastoma, embryonal rhabdomyosarcoma, ALL, and Wilms tumor. Neuroblastoma doesn't occur as a primary neoplasm in children much older than 6 years. Embryonal rhabdo, as we know, is not classically a round cell neoplasm, but sometimes when the ovoid cells are very tightly packed together, it can look like a round cell tumor. When we move on to a slightly older age group, so adolescents and young adults, we need to start considering alveolar rhabdo, Ewing sarcoma, desmoplastic small round cell tumour, polydifferentiated synovial sarcoma, still ALL, and also mesenchymal chondrosarcoma, small cell osteosarcoma, and the Ewing-like undifferentiated round cell sarcomas, including Chick and BCOR associated tumours. When we move on to older adults, the spectrum broadens because we have the more common tumours, so small cell carcinomas, small cell melanomas, along with lymphomas and leukemias. Alveolar rhabdo is still in this category, as are Ewing sarcomas, because they can occur not just in young patients, but in a wide age group, including the elderly. Polydifferentiated synovial sarcoma, round cell liposarcoma, small cell MPNST, and then things that occur at different sites or as metastatic tumours that we may not think of immediately, such as olfactory neuroblastoma, endometrial stromal sarcoma, nut carcinoma, and various myoepithelial neoplasms. So first, we need to be able to appreciate the morphologic spectrum. So we can see DSRCT on the left, very classic morphology of angulated nests in fibroblastic or myofibroblastic stroma. But Ewing sarcoma can occur in the abdominal cavity and sometimes have this sclerotic, angulated nested morphology. Polydifferentiated synovial sarcoma, Cyril has mentioned this. Normally we think of synovial sarcoma as monophasic or biphasic. We forget that it can occur as a predominantly round cell or ovoid cell neoplasm, can strongly mimic Ewing sarcoma, particularly as it is diffusely CD99 positive typically. And then, of course, we should not forget the more common cancers like small cell carcinoma and various lymphomas. Myoepithelial tumour has a very wide morphologic spectrum and sometimes can manifest as quite a round cell tumour, and nut carcinoma, being a rare type of carcinoma, can also mimic a round cell tumour. So starting with Ewing sarcoma, Prof has already covered this in detail. So we'll just skim this, but as we know, most of us are familiar with diagnosing Ewing sarcoma or its morphology, but a few brief points. This is a small round cell sarcoma characterized by gene fusions involving one member of the FET family of genes, and this family includes EWSR1, FUS, or TAF15. And let's remember that FUS gene sometimes substitutes for EWSR1. So instead of EWSR1 partnering a given gene, FUS instead partners this. And a member of this family of genes, usually EWSR1, but sometimes FUS, partners with a member of the ETS family of transcription factors. Just also for us to remember that the terms PNET, primitive neuroectodermal tumour, which corresponds to Ewing sarcoma with various neural or neuroectodermal differentiation, and Askin tumour, so Ewing tumour of the chest wall, the thorax. These terms are no longer used because there is no difference clinically in these tumours with conventional Ewing sarcoma. Ewing sarcoma occurs in a young population. 80% occur in patients who are younger than 20 years. There is a mild male preponderance, and as we know, these can occur in bone or soft tissue. They are in fact the second commonest malignant bone tumour in young adults after osteosarcomas, but when patients are older than 30, Ewing more frequently occurs in soft tissue. So this can occur anywhere in the bones. Extraskeletal Ewings comprises about 12 to 15% of Ewing sarcomas, and soft tissue Ewing sarcomas can occur anywhere, including in intracavitary sites and in the skin. And also a significant proportion can occur in viscera. So the 5-year survival is pretty good nowadays with conventional treatment regimens. It's approaching 80%. There is no way of using histology to predict behaviour, but for patients who have metastatic disease or tumours with early relapse, the 5-year survival is still pretty dismal at less than 30%. So morphologically, these tumours, as we know, are composed of very, very monotonous distributions of small round cells. And these are incredibly homogeneous looking tumours, and the cells are completely uniform with no atypia. Very high NC ratio, inconspicuous nucleoli, Sometimes there's a little bit more cytoplasm and it can be clear or eosinophilic. Here are various architectural patterns of Ewing sarcoma, but we can discern that in every case they are very monotonous and the cells look the same with no atypia. On the right, we can see that these are nested distributions rather than sheet-like, but the cells remain uniform and extremely monotonous with no stromal changes, no discernible atypia, completely evenly spaced. So that is typical Ewing sarcoma. An interesting or a helpful special stain that we can do. This is what Prof has always taught us, but Ewing sarcoma lacks any reticulin pattern. So this is, I find this very helpful, that there is a lack of any surrounding stroma. And that is useful because tumours that may mimic Ewing sarcoma, such as poorly differentiated synovial sarcoma or small cell carcinoma, will have a nested pattern with reticulin. This is completely lacking in Ewing sarcoma. There can be variable rosette formation of the Homer-Wright type with cells arranged around central fibrillary cores. Notice how evenly spaced and monotonous these cells are. So let's consider briefly Ewing sarcoma variants. So there is atypical Ewing sarcoma in which the cells are generally larger, and we'll discuss that next, and then adamantinoma-like, clear cell-like, and sclerosing. And there are not thought to be any significant clinical differences between these variants. So the concept of atypical Ewing sarcoma has referred to patients who have round cell tumours occurring in a similar clinical context to Ewing sarcoma, but with tumours that morphologically show slightly different features. So we remember our conventional Ewing sarcomas, in which the cells were very, very monotonous, small, uniform, had little cytoplasmic component, no stroma, and atypical Ewing sarcoma has a constellation, any or all of these features. The cells are slightly larger. They're rounded cells, but they're slightly larger, often with prominent nucleoli, more irregular contours, more abundant cytoplasm, less even spacing, variable cellular atypia, so at least mild focal cellular atypia. They lack that uniform spaced appearance of classical Ewing sarcoma, and there may be variable fibrous or myxoid stroma, which, as we remember, is lacking in conventional Ewing sarcoma. And many of these lack EWSR1 or FUS gene rearrangements. So atypical Ewing sarcoma, we can see nested distributions of cells. And if we hark back to those features of conventional Ewing sarcomas, again, these cells are still relatively uniform. They are rounded cells, but they are slightly more atypical. There is slightly more cytoplasm. They are less evenly spaced. There is some stromal component around them. And they just look uneven and non-monotonous. Just other variants, Ewing sarcoma can have clear cells. Ewing sarcoma can have a sclerosing picture resembling desmoplastic small round cell tumor. And then there is the category of adamantinoma-like Ewing sarcomas. And many of these occur in the head and neck. These are typified by standard Ewing fusion, so EWSR1 with FLY1. But these tumors typically have focal epithelial differentiation with keratinization and a positive for epithelial markers. So it's yet to be known whether these represent a distinct subgroup of tumours distinct from Ewing sarcoma. Typically, CD99 is diffuse and strong, so extremely diffuse and strong in the membrane of the cell, and then again a very heterogeneous immunophenotypic pattern. So 25%. Back to CD99, very non-specific. It can be positive in many other small round cell neoplasms. So we do not use it as a diagnostic factor. It should always be used in the context of a complete panel. It's also expressed in various leukemias and lymphomas, alveolar rhabdo, and as we know, poorly differentiated synovial sarcoma. But we just remember that this particular pattern of staining, diffuse and strong, essentially block positivity, strong membranous expression. So keratin is variably positive in 25% of Ewing sarcomas. We can see dot positivity here, but it can be diffuse and strong, and it can mimic, especially when Ewing sarcoma occurs as a primary neoplasm in the viscera, it can mimic small cell carcinoma. There's variable S100 protein, variable neural marker expression, and also variable FLY1 or ERG. This example shows diffuse and strong ERG expression, and genetically showed EWSR1 ERG fusion. Prof has spoken about NKX2.2. If you have it, it is a useful marker. I don't personally have experience of it, and there could be variable cyclin D1 expression. So the genetics, these are characterized by fusions of EWSR1 or more rarely FUS with a member of the ETS family of transcription factors. Most frequently, these are FLY1 or ERG, and sometimes these can be FEV or the ETV genes. And all Ewing sarcomas harbor an FET ETS fusion. However, the vast majority of Ewing sarcomas show EWSR1 FLY1 or EWSR1 ERG fusions. FLY1 is by far the most common, that's seen in 85%, and ERG fusion is seen in approximately 10%. So more rarely, EWSR1 can partner with other members of the ETS transcription factor family, and also rarely other FET family members. So FUS instead can fuse with ERG or FEV. I think Cyril has shown this slide of Ewing-like tumours and this heterogeneity of tumours in which EWSR1 is the driving gene. And so most of them are typical Ewing sarcomas, we can see that. And then the next group in red are EWSR1 non-ETS family tumours. Cyril has described these, and then more rarely, instead of EWSR1, FUS fuses to an ETS family member, and then we have the non-EWSR1 or FUS involved Ewing-like round cell sarcomas. So let's move to this category. Ewing sarcoma-like undifferentiated small round cell tumours, and try and discern how we can diagnose them morphologically and with standard immunohistochemistry. So we go back to the concept of atypical Ewing sarcoma, and just to remind ourselves, these tumours occur in a similar clinical context to Ewing sarcoma, but just have variable atypia, so some scattered focal cellular pleomorphism, more cytoplasm, more stroma, larger cells, nucleolation, and can lack EWSR1 or FUS fusion. So we can compare conventional Ewing sarcoma on the left and a Ewing-like round cell sarcoma on the right. And I know these differences are subtle, but we can see on the right, these cells, yes, are essentially round cells, small round cells, but there is variable stromal component with myxoid to myxocollagenous stroma. The cells show at least focal mild atypia and more cytoplasm. So the first one is the chick rearranged sarcoma. It's the first of the Ewing-like small round cell sarcomas. So chick rearranged sarcomas can occur in the adult or pediatric population, from children to elderly patients, but they typically occur in young adults with a median age of 25 to 35. Less than a quarter of these present in a pediatric age group, so they're more frequently adult tumours, and they occur in the deep soft tissues, particularly in the trunk and extremities, sometimes in intracavitary sites such as the retroperitoneum and pelvis. 10% occur in viscera, and primary osseous involvement is rare, in contrast to Ewing sarcoma. These are highly aggressive neoplasms. Many patients present with metastases, including to the lung, and the 5-year survival rate is much worse than Ewing sarcoma. It's only about 40%, and these have shown a dismal chemotherapeutic response to Ewing sarcoma treatment regimens. These are, in fact, relatively common, so they're the most common undifferentiated round cell sarcomas that lack EWSR1 fusions, and chick rearrangements have been found in up to 2/3 of EWSR1 negative small round cell tumours. Chick fuses with a variety of genes, but most frequently DUX4. About 90 to 95% of chick rearranged sarcomas show chick fusing to DUX4. There are other genetic events occurring, such as MYC amplification. The gene expression profile is distinct from Ewing sarcoma. So let's try and discern the differences in morphology. So chick rearranged sarcomas typically show a partly lobulated pattern of the tumor within surrounding fibrous stroma. The cells are quite uniform, and we can see that there, but there is at least focal mild atypia. And also, focally, there is some cellular spindling and epithelioid cells, in contrast to typical Ewing sarcoma. And then these cells are disposed in variable myxoid stroma in at least a third. So chick rearranged sarcomas. Again, if we just have a quick glance at them, these are round cell sarcomas, very similar to Ewing, but we can see already that these do not have the uniform morphology of conventional Ewing sarcoma. First of all, the cells are not particularly evenly spaced. The cells show a much bigger stromal component. Remember, Ewing sarcoma doesn't have a significant stromal component in the conventional type, and there is a little bit, it's subtle, but there is mild atypia, a little bit of nucleation, and the cells have more cytoplasm. The morphologic spectrum is heterogeneous, so we can see images from the WHO chapter by Dr. Antonescu and Dr. Yoshida. On the left, we can see chick manifesting as a small round cell tumor, but again, the cells have a little bit of atypia, at least focally. There is not the monotonous and even distribution of typical Ewing sarcoma, and there is more of a stromal component. On the right, we can see frank spindling. And again, let's remember that these tumors show at least focal epithelioid morphology or spindling. So immunohistochemically, the thing for us to always remember is that there is no specific immunoprofile for any of these neoplasms. About a quarter of these can express CD99, but we can see that in contrast to the diffuse and strong expression of CD99 that we see in most Ewing sarcomas, the CD99 in chick rearranged sarcomas is focal, if it's there at all, and it's often weak to moderate. We do not see that even strong appearance that we see in Ewing sarcoma. There can also be variable cytokeratin, S100 protein, desmin expression, although not myogenin, variable keratin, even variable Fly1 and ERG, but again, we do not expect diffuse and strong nuclear Fly1 or ERG. NKX22 is typically negative, and relatively useful if you have these markers are the diffuse and strong nuclear expression of WT1, seen in up to about 90% of cases, and strong nuclear expression of ETV4, again seen in a similar proportion of cases. So next, sarcoma with B-core genetic alterations. So B-core involved sarcomas are rarer. They account for approximately 5% of EWSR1 and FUS negative small round cell tumors, and these genetic events lead to B-core protein overexpression in the nuclei. These can occur in both bone or soft tissue. Let's remember that the chick rearranged ones are more frequently soft tissue neoplasms, but the B-core associated sarcomas have a similar anatomic distribution to Ewing sarcoma. Also similar to Ewing sarcoma, these occur predominantly in a young population, predominantly children, usually aged between 7 to 13. And more than 90% of patients who have these neoplasms are below the age of 20 years. So sarcoma with B-core genetic alterations can occur at multiple sites, including trunk extremities, but especially the pelvis, the lower extremity, and paraspinally. They can also occur in viscera and in the head and neck. The 5-year survival is much better than for chick rearranged sarcomas and is roughly similar to Ewing sarcoma at about 75%. And these tumours, they can metastasize to various sites, including viscera, but these tumours have shown, in many cases, a relatively favourable response to conventional Ewing sarcoma treatment regimen. So overall, not as aggressive as the chick-rearranged sarcomas. So BCOR gene can cause tumorigenesis in two ways. So the first way is that it can fuse to a partner gene. That's a variety of genes, but most frequently it is CCNB3. So standard fusion. And the second way in which it can lead to oncogenesis is through BCOR internal tandem duplications. So there are multiple duplications of this BCOR sequence within an exon, and these are sarcomas with BCOR internal tandem duplications, or ITDs, comprise two main ones in very young children. So in infantile undifferentiated round cell sarcomas and primitive myxoid mesenchymal tumours of infancy. So we are very unlikely to come across these at all, with most of us working in adult pathology. BCOR family tumours share a similar gene expression profile, and they have a morphologic spectrum. So we can already see that, yeah, these are somewhat rounded cells, small rounded cells, but they're definitely more atypical than Ewing sarcoma. So these tumours are composed of primitive, variably round to spindle cells with scanty cytoplasm, but typically in focal, at least focal myxoid or collagenous stroma, and frequently these have quite a rich background vascular network or a delicate capillary vasculature. In many areas, at least focally, there is frank spindling, and sometimes the spindle cell areas are very predominant and sometimes occur in a fascicular distribution with an arcuate vascular pattern. And when this pattern prevails, BCOR sarcomas can highly resemble synovial sarcoma or MPNST. Again, let's look at the morphologic spectrum. So on the left, we see a tumour that somewhat resembles Ewing sarcoma. We can categorize it as a small round cell sarcoma, but we can already see that there is discernible, at least focal atypia, stromal component. The cells have more cytoplasm, and they are not evenly spaced. We can see now that this is not typical of Ewing sarcoma. On the right, we can see where the spindle cell morphology is prominent and where it can resemble a spindle cell sarcoma. A couple more examples from the book. BCOR CCNB3 sarcoma, mostly as ovoid to rounded cells on the left, and this on the right is a BCOR ITD sarcoma manifesting as an undifferentiated round cell sarcoma. So a few brief words on BCOR associated sarcomas with internal tandem duplication. So these represent two types: infantile undifferentiated round cell sarcomas and primitive myxoid mesenchymal tumours of infancy. These can occur at a variety of soft tissue sites, including the trunk, retroperitoneum, and head and neck, although the extremities are typically spared, and these typically occur either within the first year of life or are present at birth. So these tumours account for 50% of tumours classified as undifferentiated round cell sarcomas in infants, and are seen in the majority of primitive myxoid mesenchymal tumours of infancy. And we can see an example of this here, where we have undifferentiated round cells in myxoid stroma with a variable vascular pattern. Again, this is to illustrate the morphologic heterogeneity. This is a tumour type in which our understanding is still evolving. Again, immunohistochemically, there is no specific immunohistochemical finding, and we need to know the spectrum of positivity. So if you have BCOR or CCNB3 markers, again, I have never used these. You can see overexpression in nuclei in a diffuse pattern. 60% of these, so more than the chick-rearranged sarcomas, show variable CD99 expression. Again, typically not in the diffuse way of Ewing sarcoma, We can see CD99 here. This is pretty diffuse and strong, but generally they are not as diffuse and strong as in conventional Ewing sarcoma. 90% can show BCL2, 60% can show variable CD117, 75% can show strong nuclear TLE1. So as Prof was saying, TLE1 is not is a supportive but not specific marker at all for synovial sarcoma, and is expressed in a variety of other tumours that can be in the morphologic differential diagnosis. And about 70% show SAT-B2 expression. So moving on to desmoplastic small round cell tumour, briefly, because most of us are very familiar with the morphology of this in the clinical setting. This was first described about 30 years ago by Dr. Gerald and is defined as a malignant mesenchymal neoplasm in which small round cells, very Ewing-like, are present in extensive desmoplastic stroma. And this is known for its polyimmunophenotypic profile. So it is positive for a variety of markers of various lineages, and it is characterized by EWSR1 WT1 fusion. So this happens in a very characteristic setting, typically in children and young adults. A peak is in the 20s, so the third decade, with a male preponderance. And the classical manifestation is in the abdomen and pelvis, with tumor present as multiple seedlings and serosal implants. More rarely, it can occur as a primary neoplasm in other sites, including paratesticularly, in the ovary, in the head and neck, and the limbs, and also in visceral sites. This is an extremely aggressive malignant neoplasm with a dismal survival, and morphologically, this is composed of these angulated or sometimes more rounded nests of very uniform cells. If we look at the cells, they essentially look like Ewing sarcoma. There's no atypia here. And these are present in extensive desmoplastic stroma, composed of bland fibroblasts or myofibroblasts. Again, we can see the very angulated nests of uniform rounded cells. There is scanty cytoplasm, variably associated with mitoses and necrosis. This is the stroma, very bland spindle cell stroma, and we can see the marked angulation of these nests with extensive stromal changes. Some morphologic variations. These tumours can sometimes show more epithelial-like morphology with glands or rosettes. Sometimes there are rhabdoid inclusions, and sometimes there is cellular spindling. But typically there will be more conventional areas of round cells in other parts of the tumour. Sometimes it can be completely solid without the presence of the stroma, and that can, of course, be confusing because that looks like Ewing sarcoma. Look at the blandness of the cells on the right. This tumour has a more acinar-looking, somewhat neuroendocrine-looking appearance. And DSRCT is known for its multi-immunophenotypic differentiation with divergent differentiation towards epithelial, muscle, and neural lineages. And let's remember that any given tumor does not have to show all of these lineages. It can show one or two or all. So we have to also be aware of the spectrum of immunohistochemical differentiation. So positive markers on the left, negative on the right. So these are associated with strong desmin expression, but myogenin and MyoD1, so the myogenic markers that indicate rhabdomyosarcoma, are consistently negative. Cytokeratin, variable expression, WT1, the C terminus, so it depends which terminus of WT1 you are using, but there will be diffuse and strong expression if you are using C terminus WT1, but not N terminus. There is variable neuroendocrine or neural marker expression, INI1 is retained, and also variable CD99, but not the characteristic strong diffuse expression that we see in Ewing sarcoma. Negative, other than myogenin and MyoD1, are S100 protein and other melanocytic markers and hematolymphoid markers. So looking at the immuno, typically diffuse and very strong desmin, but this can be variable. On the right, we can see the diffuse and strong nuclear expression when we are using C-terminal WT1. It will be negative if we have WT1 N-terminal. Dot-like desmin expression on the left. And then CD99 expression on the right. So we need to be aware that there may be focal weak expression, but certainly not the diffuse and strong membranous staining that we can see in Ewing sarcoma. So that's quite a good and helpful clue. A very strong keratin expression. Again, on the right, we can see the nest really strongly staining, and that can look like small cell carcinoma, but we have to remember the clinical context of intra-abdominal deposits in young patients, dot-like keratin on the left. So these tumours are defined by EWSR1 WT1 gene rearrangement, present in almost all cases, at least 97%, and this generates a chimeric fusion protein which acts as an aberrant transcription factor. So we already know from Prof's lecture that EWSR1 break apart probe is not specific. So if we see EWSR1 break apart probe break apart with FISH, unless it is a very distinct morphology with the correct immunohistochemistry, we cannot define that it's a desmoplastic small round cell tumour. Particularly in cases that are that show a very solid morphology or have limited sampling in a core biopsy. So it's ideal to have RT-PCR or NGS, although EWSR1 in a very striking morphologic and immunophenotypic and clinical context means that we can call it DSRCT. Ewing sarcoma can have a sclerosing pattern, and this can occur. This was actually a tumour that occurred in the abdominal cavity, highly resemblant of DSRCT, but showed standard EWSR1 Fly1 fusion transcripts and showed diffuse and strong CD99. Alveolar rhabdomyosarcoma is a round cell rhabdomyosarcoma that typically occurs on the extremities and trunk, but rarely it can occur in intra-abdominal sites, or it can present as a metastasis. And here we can see that there are solid nests lacking the alveolar architecture with surrounding sclerotic stroma highly resemblant of desmoplastic small round cell tumour. But these tumours will show diffuse and strong myogenin and or MyoD1 expression. Similarly, sclerosing rhabdomyosarcoma is a rare rhabdomyosarcomatous subtype, which may show some morphologic similarity to DSRCT, but again will show variable myogenic marker expression, typically MyoD1. So we now move on to alveolar rhabdomyosarcoma, which is the classic round cell rhabdomyosarcoma. And again, most of us are familiar with this alveolar pattern of small round cells with the central disc cohesion and dropout, with a picture that is very resemblant of pulmonary alveoli. So rhabdomyosarcoma is the commonest soft tissue sarcoma of children and adults, but embryonal rhabdomyosarcoma is predominant, so more than 60% of cases are of embryonal subtype, and we know, of course, that embryonal rhabdomyosarcoma is not a small round cell neoplasm, but has a very heterogeneous morphology and sometimes has sheets of ovoid cells which can mimic a round cell sarcoma. Alveolar rhabdo accounts for about 20% of rhabdomyosarcomas of young people. It chiefly affects adolescents and young adults, with a most prominent in ages 10 to 25, typically occurs in extremity or sometimes truncal sites, and there is a significant minority population that occurs in head and neck sites, including the nasal cavity. This is a highly aggressive tumour with a very poor prognosis. Often this presents with widespread metastases, sometimes with a leukemic picture of extensive marrow involvement completely replacing the marrow. These are composed of rounded cells, typically with alveolar nests with this central dropout, so central empty spaces, and also typically there are these broad fibrous septa, sometimes with tumour giant cells. This is the classic morphology, but the morphology can vary considerably. Sometimes the nests are more solid and an obvious alveolar architecture is lacking. Sometimes there can be variable cyst formation. The cells are relatively uniform, but there may be a little bit of mild atypia. This really varies. They look a little bit more, little bit bigger than Ewing sarcoma, although sometimes they are very, very monotonous. So a little bit larger than standard Ewing sarcoma. We can see giant cells, tumor giant cells on the left, and these characteristic fibrous septa. The solid variant shows the absence of nests completely, and sometimes the cells can show a clear cytoplasmic change. The tumour on the right shows angulated nests with a solid look in fibrous stroma, mimicking DSRCT. There can be variable clear cell change, and it's unusual for alveolar rhabdomyosarcoma to show any rhabdomyoblasts. So this is an extremely unusual finding. Sometimes post-treatment, the cells can mature and be rhabdomyoblastic, but it is extremely rare to see these in the primary treatment-naive setting. This tumour on the right is a nasal cavity tumour and shows extensive replacement of the subepithelium by alveolar rhabdo. And again, there is no specific architecture there, so this will be very reliant on immuno. So typically, alveolar rhabdomyosarcoma is diffusely and strongly positive for desmin, and also diffusely and strongly positive for myogenin and frequently for MyoD1. This is in contrast to embryonal rhabdomyosarcoma, which has a much more varied picture of expression of desmin and myogenin and MyoD1, all of which will be expressed to some degree, but this can vary from very focal desmin and myogenic markers to very strong and diffuse, whereas alveolar rhabdo characteristically has diffuse and strong expression of all of these markers. Genetically, this tumour is defined by PAX3 or 7 fusing with FOXO1, and this has been shown in up to 90% of neoplasms. PAX3 is the more common finding. PAX7 is rarer. There has been a tendency for better survival in PAX7 cases, but this is not clear-cut. As Prof was saying, there are rarely any specific fusions anymore. Until relatively recently, it was thought that PAX FOXO1 fusions were specific for alveolar rhabdomyosarcoma, but now we know that a minority of biphenotypic sinonasal sarcomas show PAX3 FOXO1 expression. So it's no longer a specific fusion. There are no morphologic differences between PAX3 or PAX7 fused cases, and very rarely there are variant fusions in which PAX3 can fuse with a variety of partners or FOXO1 can fuse with FGFR. So just for us to be aware that we will not always be able to confirm alveolar rhabdo in a morphologically consistent case if we are using FOXO1 probes, which is the typical probes that we use in most fish labs. There is the concept of fusion-negative alveolar rhabdomyosarcoma. These are thought to represent a heterogeneous group of cases. There can be a number of reasons why an alveolar rhabdomyosarcoma-like tumour may be negative for PAX FOXO1 fusions. These tumours may have one of the variant fusions that we just mentioned, or these fusions may be present at low levels which are not detectable molecularly, i.e. there is a low expression of the normal fusion, or they may be variant fusions that are not detectable with standard techniques. There appear to be distinct gene expression profiles between fusion-negative and fusion-positive alveolar rhabdomyosarcomas, and it's currently thought that the fusion-negative ones are actually embryonal rhabdomyosarcomas that are likely misdiagnosed as alveolar. So briefly, embryonal rhabdomyosarcoma, just to specify, we know that this is not a round cell rhabdomyosarcoma because it's largely composed of a very heterogeneous array with a morphologic spectrum of ovoid and spindle cells, invariably myxoid or collagenous stroma. But sometimes the ovoid cells can be very solidly packed and resemble alveolar rhabdo. But we can discern on the picture on the left that there is at least a little bit of atypia, and the cells are not the extremely homogeneous looking ones of alveolar rhabdo. These occur at a younger overall age than alveolar rhabdomyosarcoma, chiefly in children who are younger than 12 years old, and in different sites. So alveolar rhabdo occurs principally in the extremities and trunk, sometimes in the head and neck. Embryonal rhabdomyosarcoma is uncommon in the extremities and occurs in a variety of sites, including the head and neck, genitourinary tract, pelvis, retroperitoneum, and biliary tract. And it has this very heterogeneous morphology of spindle cells and ovoid cells, frequent rhabdomyoblasts in myxoid stroma. And we'll just sail through some other round cell sarcomas. Round cell liposarcoma, formerly round cell liposarcoma, now known as high-grade myxoid liposarcoma. I'm just putting this in because we often forget that round cell liposarcoma can be diffusely round cell, in which case we can mistake it for Ewing or other round cell sarcomas. And these, we can see the hypercellular round cell areas predominating. Let's remember the clinical picture. Myxoid liposarcoma chiefly occurs in the deep soft tissues of the extremities or trunk and is associated with DDIT3 fusing to FUS or EWSR1. In myxoid liposarcoma, we often see transition to more hypercellular areas. The main thing for us is to know that round cell liposarcoma exists and is rare, and look for typical areas of myxoid liposarcoma, at least focally. So we see a little bit of myxoid stroma if we have an index of suspicion, and then we can see typical areas, even if they're small, of myxoid liposarcoma with prominent amphiphilic myxoid stroma with small numbers of scattered lipoblasts and this curvilinear architecture of small thin-walled vessels. Prof has talked about poorly differentiated synovial sarcoma, so we will just skim through this. This is, again, just for us to have an index of suspicion that it exists, because, again, we forget that it can occur, and it has a diffuse and strong CD99 expression typically, so we think it's Ewing sarcoma. These occur in youngish adults. This variant of synovial sarcoma has a poorer prognosis than conventional synovial sarcoma. Quite frequently, there are typical areas of spindled synovial sarcoma, at least focally, and perhaps a hemangioparasitic vascular pattern. You can see HPC pattern here. And immunophenotypically, these are similar to conventional synovial sarcoma with very focal keratin and EMA expression. Also diffuse nuclear TLE1 in more than 90%, which we would not expect in Ewing sarcoma. Associated with SS18, SSX fusions for most cases, and Prof has spoken about those. Extraskeletal mesenchymal chondrosarcoma, again discussed by Cyril. This is a high-grade malignant biphasic primitive mesenchymal tumor with a well-differentiated hyaline cartilage component. Again, this is for us to have an index of suspicion for it when it occurs in soft tissue, particularly in core biopsies where we may not see the chondroid elements. So when we see a field like this, we think of small round cells, very much in a Ewing-like pattern, perhaps poorly differentiated synovial sarcoma, but we have to think of the clinical context. 40% actually occur in somatic soft tissues, particularly the extremities. A proportion can occur in head and neck. Rarely in the viscera. It occurs in young adults and is a very aggressive neoplasm with a 50% 5-year survival. Again, the best way for us to not miss it is to remember that it exists and the morphologic spectrum. So it's biphasic tumor composed of essentially small round cells with foci of well-differentiated hyaline cartilage. And these may be small, tiny nests, so we need to look for them. Frequently there is a hemangioparasitic vascular pattern in the background, and sometimes there can be osteoid deposition. So let's remember that prominent hemangioparasitic vascular pattern in the background. These are diffusely and strongly positive for CD99, like Ewing sarcoma, with variable S100 protein positivity because there is chondroid differentiation, and there can be aberrant other markers, including EMA, desmin, myogenin D1. It is negative for FLY1, SMA, keratin, and GFAP, and it's associated with HEY1, NCOA2 fusions, and is the only chondrosarcoma with this fusion. And we can finish off here by just reminding ourselves of other neoplasms that can manifest with small round cell morphology. Small cell carcinoma, we can see a little bit of atypia here. Nut carcinomas, myepithelial tumors, widespread morphologic variation, but can manifest with round cell sarcoma-like changes. Sometimes we completely forget about endometrial stromal sarcoma, and sometimes it can occur in an older female patient who has a history of hysterectomy, histology unknown, 20 years ago, and we see a pelvic recurrence of a round cell neoplasm or sometimes a lung metastasis. So remember this, and also, of course, lymphoma and sometimes seminoma. So I think we'll finish there. So thank you, everyone.